Hello and welcome to O300 on the Floor, which is a part of the Nurse Residency Program Session number 3 presentation. We're going to be doing this as a recorded webinar this time as opposed to our usual live class. Overview for this. Again, this is part of the Nurse Residency Program Session 3 that we usually held in the Life Support Learning Center. We're going to walk you through your responses to a patient who rings on the call bell about 3 in the morning. I will give you time at several steps to decide what you want to do next. We'll actually have a slide up that says time to think. You may decide that you want to do several things, which is okay. Or you may decide to do one thing. If you do decide to do several things, which one do you want to do first? After you have some time to think, I'll then tell you one option of what you could do next and why I think that's a good idea to do that. There are lots of possibilities of what might you do next. And I'm not necessarily right, but I should at least be able to explain my thought process to you. This is going to come as an adult patient on a gen med floor. However, regardless of your home area, by the end of this, I'm pretty sure you'll see how this will be useful for you. So here we are. It's O300. You have a 56-year-old male patient on your general medicine floor. He's here for a pancreatitis flare-up. We've seen him before, about every 6 months. At O300 on day number 5 of his stay, he rings on the call bell. What would you like to do? So I'm hoping that respond to the call bell was part of your answer, possibly all of your answer. One thing to think about though, as you are responding to the call bell, as you're coming into the room, take just a quick second, consider seeing patient and your own safety. As I'm looking into the room, is there anybody there with a pillow ready to throw at me, who looks really mad, who's got a water glass or something in his hands, anything like that? It rarely happens, but we do want to just do one quick little 6 foot away ping. Is this okay for me to get myself into? Just to make sure. So initial patient contact, you're now in the room. It is safe for you to go in the room. Everything looks fine. There's no one's therapy dog there trying to bite you or anything else like that. What would you want to do as you're entering the room? Right. One thing you can do, and what I would suggest, is doing a doorway assessment. Even before I get near the patient, I can already start assessing them. Right. Your nursing school probably said told you that you were assessing all of your patients all of the time. And this is one example of that. From the doorway, I'm not even within 6 feet of this person. Is the patient awake, alert? I hope so, because he pressed on the call bell like a minute ago. Calm or in distress? Airways intact? Yes, no. Breathing's okay? Yes, no, maybe. Sometimes you get maybe on that one. What's the rate, work of breathing, bad, are there bad breathing sounds? And I'm not looking here for exactly what number. I'm looking for fast, slow, normal. Can I hear him from 6 feet away? That's probably a bad sign, right? Is patient circulation okay? I can't do a pulse even. I'm not within 6 feet of him, but skin looks okay. Pale, flushed, red, blotchy, gray. What's going on here? This doorway assessment is how your preceptor knows the patient's in trouble before you're even in the room, right? This patient's septic. We should do something about it. How do you know? I'm not even in the room yet, right? And that's how they're doing that. They're doing a quick, fast, one time look at them from the doorway. What's my initial gestalt about how this guy is looking, how this patient looks? So in this case, the patient's awake and alert, no apparent distress, including breathing. Airway is patent, as the patient can speak back to you. Breathing is normal, or at least normal-ish. Rate, work of breathing, depth of breathing, they all seem reasonable. Circulation appears normal. Skin color looks like the patient's usual skin color. All right. So now what would you like to do? Patient doesn't appear to be having an obvious life-threatening problem. Right? So I can interview them and assess the patient in a little bit more detail. If I found something on that first quick look across the room that said, oh my goodness, this is bad, I should do something about that. My patient's respiratory rate is now 4. I need to do something about that. I need a bag valve mask. I need some help in the room. Right? And all of a sudden, things are going to start moving much, much faster if you're finding something on that first quick across the room look that says, oh my goodness, this is not good. Right? My patient's not looking at me at all. Really, I'm going to move forward a little faster and start making them want to respond to me. I want to get a response out of them. But in this case, nothing obvious. The patient does not appear to be in any major distress and is willing to talk with you. All right, let's go do some interview and some assessment. What can I help you with? Patient says he's had a burning sensation in his chest just above the stomach. He's consulted with Dr. Google and thinks it's heartburn. So now what would you like to do? Well, some options, and I'm not promising all of them are good. Do you want to check for PRNs for heartburn? Ask more about the burning sensation. Get a new set of vital signs. Reassure the patient it's probably not heartburn. He just started PO. He just restarted his PO foods after his pancreatitis. Can't be heartburn. Which of those do you think would be better, and which of those do you think, yeah, maybe that's not the way I want to go with this patient? Checking for PRNs for heartburn, it's a reasonable thing to do, but it's also you're locking down very quickly on what your patient says is going on is the thing that's going on. And sometimes they're correct, but not always. So I might need to do that, but maybe not right yet. Do you want to assure the patient it's probably not his heartburn? He just restarted the PO foods, just recently. This might turn out to be nothing. Frequently it does. Frequently, nothing bad's going on. But the patient's telling you something new. I'm not sure I want to just sort of brush it away. My name's John Howard. I've been doing nursing now for about 14 years. That's impressive. Okay, 14 years, and I've been an EMT since 1989. There's a little person in the back of my brain that I have been trying really hard to pay attention to. I'm just started doing it. Generally speaking, if my patient's telling me something new, I ought to listen to that person in the back of my brain who says, you need to do some more work. Even if that means I need to do some more work, but I need to go poke at this a little bit more. Find out more about what's going on. I would ask more about the burning sensation and get a new set of vital signs. So here we go. Burning sensation. When did it start? What does it feel like? How bad is it? 0 to 10 scale. Have you ever had anything like this before? Does anything make it better or worse? Is there any tenderness or mass in the abdomen? Is there any chest pain or shortness of breath? Is there anything else going on that I can look, listen, or feel for that's helping me to figure out what's going on here? So you ask those questions and do those things, and you get some results. Started about an hour ago, feels like a burning sensation. How bad is it? Well, he doesn't want to really say bad. It's a burning sensation. He can feel it. And I've never had anything like this before. Nothing makes it better or worse. There's no tenderness or mass in the abdomen. Even when you push on it, he doesn't extra flinch or anything like that. There's no chest pain, no shortness of breath. Not really. Anytime your patient gives you an answer of, no, not really, that might be worth a little extra poking at as well. What do you mean by not really? Is there any shortness of breath at all? Right? Is there any chest pain at all? Well, it's not really pain, it's a burning sensation. Oh. Have you ever had anything like that before? No. Okay. On a 0 to 10 scale, How bad's your pain? It's not really a pain. Oh, okay, right. On a 0 to 10 scale, 0 is nothing, 10 is the worst you can imagine. How bad's that burning sensation? Well, it's about a 7. Cool, pain equals 7. Because really, that's sort of a pain. They're telling you it doesn't feel good. It just may not feel like the pain they're used to. So I need to poke at it a little bit more. And the 7 is not exactly small. Interesting stuff going on here. Now what? You want to page the LIP for something? A lot of people, when we do this class live, a lot of people say, yeah, we need an order for Tums because he has no PRNs for any heartburn issues. You could, right? A lot of people at this point do say, yes, I want to page the LIP and make sure they know that this is happening. Okay, which is fair. Absolutely. If the physician went into my patient's room and did something and found out something about them, I would want the physician to tell me about it too. So sure, page the LIP. Now, what page level do you want to use? There's five. There's FYI, routine, urgent, the urgent with the breakthrough, so they can't sort of squelch it, and then come now. I have the ability to work with some of the physicians with simulations and things like that. They report that prioritization of pages is actually extremely helpful for them. They really appreciate it, and they believe that the prioritizations that the nurses are doing are accurate, and again, are very helpful for them. Right? So we should keep doing that. Right? Think about your cross-covering night shift physician. They may have up to 40 patients, most of whom they've never seen before. They need to know, how worried are you about this patient? How much do I need to pay attention to this? Right? I need a doxystate sodium order renewed is low priority, and you can tell them that by your pager level. I'm thinking my patient's trying to die is a very high priority, and you can help tell them that by using the correct pager level for it. So, what do you want to do next? So maybe a new set of vital signs here would be good. We did talk about that earlier. Sure, we have a new set of vital signs. There they are on the screen for you. So are these good or bad? And how would you know? I mean, they're within normals, mostly anyways, right? Maybe you should compare them to something else. So the question is still there. Are your current vital signs good or bad? It's not just a snapshot one point in time, and they fit between certain specific maximums and minimums. It's also how are they doing compared to what the patient had previously. Go back 24, 48 hours, right? Epic has the trends on it, so you can see it graphically if you want to, but it will help you figure out where the vital signs been over the last 24, 48, whatever you want to do, hours. How is this patient's vital signs? Are they better? Are they worse? Are they good? Are they bad? My personal argument, I'm not that far off. I don't I don't see anything that's like screamingly off at me right now. They are trending a little bit in a worse direction, but not hugely. Is that just normal variation or not? Hard to tell. I am noticing though they tend to be trending slightly in the direction I don't want them to go. So I got to park that in my head for a second and keep poking. Abdominal assessment shows no distension, no increased pain on palpation, no rigidity. He had a small bowel movement several hours ago. Respiratory assessment shows no increased work of breathing, no abnormal breath sounds. And the heart assessment shows a normal S1, S2, and nothing else. Okay. Now what would you like to do? I mean, you've checked him out. He doesn't look like he's going to deteriorate immediately. So what might be happening to him? So one of the things that you might want to do at this point, and I would actually at this point strongly advise for this, is what might be happening for this guy. It's called a differential diagnosis. At least on the physician side, it's called a differential diagnosis. But nurses don't do diagnoses, right? When we do, there are nursing diagnoses. I actually am a fan of the ones that say risk of, because I'm trying to anticipate forward what might happen rather than seeing something that's already happened. Although I mean, I need to know that too. But if I can anticipate forward and keep something from happening in the first place, that's probably the best way to treat it. But what might be happening with him here now? Maybe he has pancreatitis. I mean, after all, that's why he's in the hospital. He might have heartburn. Maybe Dr. Google's correct. It does happen occasionally. Maybe he's got constipation, small bowel obstruction. All that so far, though, has been like GI stuff. I should spread out my thought process here. What else might be happening to him? Maybe he's having a heart attack. Maybe he's having anxiety. Maybe it's a PE that's shown up in some of our previous sessions. It's an abdominal aortic aneurysm that's shown up on some of our previous sessions. The point for the differential diagnosis is a wide spread of what might be happening to him, regardless of how well it fits at the start. I'm just going to brainstorm a bunch of things and then see what I can do with that. If these are some of your differential diagnosis possibilities, what would you like to do next? Can I do anything to help clear some of the stuff off the differentials list? And if so, how? Could I do my assessment? I've done some of it already. So can that assessment help me clear things, right? I'm not necessarily looking to absolutely say, yes, you have this, or no, you don't have that. I'm looking to see which one's most likely, which one makes the best story for what my patient is having. And I can sort of sort that two ways in terms of what's the best story. One is sorting it by what's most likely, and one is sorting it by how bad is it. So what's most likely? For him, it might actually be the heartburn. Which one's most likely to kill him in the next 5 minutes? Is not going to be the heartburn. That would be the heart attack. Maybe the PE or the abdominal aortic aneurysm. But those two things are different. You might have two lists that are slightly different. So how can I make the story for one of these be much better than all the rest? So a straight up assessment is a good thing. Physicians call this a history and physical. We've already done a bunch of that. What's going on? How are you feeling? What's this stuff feel like? And then go poking, listening and feeling to things, right? Can I do anything else? Can I do anything else as a bedside nurse? I could do a 12 lead. I could ask for labs. I need a physician order for labs. I could do a blood glucose maybe. Anybody who's got a diaphoresis, a cold sweat, for me is going to get two things. One's a 12-lead EKG because they might be having a heart attack, and the second is a blood glucose because their sugar might be low. Both of those are really notorious for making a cold sweat. So I can do those things. Maybe get a urine sample if I'm thinking there's something with the urine going on with this, right? There's things I can start doing to help try to figure out what's going on with this. So now we're going to take this patient and we're going to do two different variations of this patient. This is variation number one. In a few slides, you're going to see variation number two. We'll make it obvious when we're switching patients from variation number one to variation number two. But this is patient variation number one, and the next few slides are for that first variation of that patient. So here's his 12 lead. Let's say it looks like this. And the machine read on it, it says up near the top, acute myocardial infarction suspected, or something along those lines. Might that make you a little nervous? I'm hoping you say yes to that. So what would you like to do now? Okay, so we found something that's really not good for the patient, and it can be lethal and can move very quickly. So don't leave your patient. You're going to call a lot of people in to help you, but you are going to stay with your patient. Page your LIP. This has now become a come now page. Right back when we were asking for PRNs for heartburn, that would probably be routine. This is a come now page. I need you in this room, or minimum calling me back on the phone inside the next 5 minutes. Right? I need an LIP to confirm the read of that EKG to see if this guy's having a heart attack or not. I would call Met. I would tell your charge nurse. Because if your charge nurse suddenly has people running onto her floor at 3 in the morning and she doesn't know why, you're going to have a very interested charge nurse showing up at the door of your room. Tell your charge nurse early in the process. Get some more help from the other folks on your floor. I'm going to need a couple more people in here just to make some stuff happen for this patient, and continue to care for your patient. You are still the nurse in charge of this patient. When Met gets there, which nurse is in charge of the patient? And the answer is you are. Met is there to help you. They can do an awful lot of stuff for you. They're great. I wholeheartedly encourage the use of the Met team when you need them. But you are still in charge of your patient. They can help, they can make suggestions, they can get a bunch of stuff done very quickly, but you're still in charge of your patient. What does this patient have? This is an ST elevation myocardial infarction. The fancy name for it is that, or a STEMI. The unfancy name for it is he's having a heart attack. Where does this patient need to go? Cath lab. Cath lab isn't open at 3 in the morning. There's nobody there. There's staff who are on call to come in, but they have up to 30 minutes to have that room ready for you. So you might have this patient for a little while. A little sidebar here, acute coronary syndrome comes in 3 flavors. The one we just saw, ST elevation MI or STEMI. It's found by doing a 12 lead. You can't find it any other way. You must do it at a 12 lead to see the ST elevation on the 12 lead EKG. They needed to go to a cath lab now. We're going to roto-root them and open up a heart vessel so the heart still has blood flow to it. Frequently, this involves placing a stent. A second version of ACS is non-ST elevation MI or non-STEMI, NSTEMI. That's usually found by labs. UVA uses troponin for this. Frequently, they get a heparin drip if they're having a non-STEMI and a cath lab appointment tomorrow. There's not been any studies that show any improvement in the patient's condition or course by sending to a cath lab immediately for an NSTEMI. Unstable angina or angina, depending on how you want to pronounce it. This is a patient who comes in and says, I used to be able to walk 4 blocks before I get short of breath. Now I can't make it to my mailbox. Your angina changed. It's found by a history and physical. And sometimes they'll get brought into the hospital to adjust meds and basically get tuned up. So also now, in general, not necessarily for our patient, but in general, what would make you want to do a 12-lead EKG? Here's some possibilities. Chest pain, right? Chest pain is what you have when you have a heart attack. Sometimes. Chest pain, pressure, discomfort, a burning sensation, heartburn. I'm not having a heart attack. I'm just having some heartburn. People are great about not describing this as pain. And this is a little bit of what I referred to earlier. Right? I'm not having pain. I'm having a burning sensation. Oh, well, how bad is that burning sensation? Well, it's about a 7. Okay, so pain equals 7. There are lots of things that are chest pain equivalents. Pain, pressure, discomfort. It feels like an elephant sitting on my chest. At one point, I wanted to do a scale, right? It feels like a mosquito sitting on my chest is one end of the scale, and it feels like an elephant sitting on my chest is the other end of the scale, right? In the middle, you could maybe make like a Labrador Retriever. So, but that's all still, to some degree, an indication of pain, even if they don't want to use the word. Heart racing or going too slowly would be great use for a 12-lead. Syncopal episode, yes. Especially someone who's in a hospital bed at the time they have a syncopal episode. Really? Who faints in bed? Something's going on there. Difficulty breathing, right? We're moving away from the obvious I'm having chest pain or a heart problem. Difficulty breathing sometimes is it, what they'll come in with. Unexplained weakness or fatigue. Anything weird between the neck and the waist. If you've got something there, you might want to consider an acute coronary syndrome. If they came in because we know they have a hole in their stomach and we're waiting tomorrow to send them for surgery to repair the hole in their stomach, and they're reporting that I have pain around my stomach, that one I understand, right? That's a pretty good story for you're having pain because you have a hole in your stomach. But the person who comes in for, let's say, a knee replacement, and now their chest feels unusual, well, that's not because they're here for a knee replacement. That's something else. And that's one of the things that's going on with this guy. He's got a diagnosis of pancreatitis. But right now, for this, he's undifferentiated. Nobody knows what's happening to him yet. We're going to start working our way through this by using that differential diagnosis and our assessments and vital signs and all those things to try to start figuring it out. I got to file on sidebar. I'm back. So there's a protocol order for 12-week. Do I need to talk to an LIP and say, please, 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 may I do a 12-week on my patient who I think is having a heart attack? No, you don't have to do that. There's a protocol order for this. It's rapid EKG 12-week. Search for rapid EKG or ECG. Your patient's attending is a physician. Please make sure you set it to per protocol as the ordering type, not verbal of readback, which is I think what it defaults to. Because verbal implies that the physician's in the room with you, and they're not right now. We're doing this per protocol. Once an EKG is complete, it must be read by an LIP. Regardless of what the machine says, it must be read by an LIP, preferably within 10 minutes. Right? If you set this up correctly, the EKG will actually pour into Epic, and the physician can read it from anywhere in the hospital. But someone needs to read it within 10 minutes. Otherwise, the thing is useless. And one other thing with this is that you should not be doing a protocol order for a routine like EKG on admission. Physicians can place their own routine orders. This is a protocol order because right now, as a nurse for this patient, I'm the only person who knows he's having this. The physician can't place the order because they don't know about it yet. So I can put this in as a protocol order. Right? So patient number 1, yep, off to the cath lab, having a heart attack. This is now variation number 2, the other pathway that you might go down with this. I have done a 12-lead EKG. Here it goes. It prints and it looks like what you see on the screen there. And the EKG machine read is normal sinus rhythm. Am I worried? No. Comes back fine. Do I still need an LIP to read it? Yes. Because I've taken a 12-lead generator to one of our 12-lead machines here at this hospital, set it for anterior STEMI, and from what I saw in the printout, it looks like there's ST elevation in 2 contiguous leads, which is the definition of a STEMI, and the machine read it as normal sinus rhythm. So all EKGs must be read by an LIP, someone who can read the 12-lead. Now this one comes back absolutely stone cold normal. There's not a thing wrong with that thing. Did you do anything wrong by doing the 12-lead? Nope. You proved the guy wasn't having a heart attack. I think that's a reasonable thing to prove. Right? Most of the EKGs you do, probably actually well above 90%, will come back normal. But you will be very happy that you did it that one time in like your career, or at least during the course of a year maybe, when it comes back as something bad, a STEMI or something else. So why do we do this session? Why do we set you through this? There's really 3 reasons. One is critical thinking. We want you to apply your critical thinking to all of your patients, right? Being thoughtful about what might be happening here. This might not be heartburn. This might be something else, right? Now, I'm going to go off on a riff here just for a second. I'm going to give you variant number 3 on this patient. I don't even have a slide for it. I'm going to give you variant number 3 on this patient. It's the same guy. He's calling at 3 a.m. for the same reason. He's got exactly the same symptoms. It's a burning sensation right around the stomach. And this is day number 5 for him. And you've had him for all 5 days. Why are you working 5 days in a row? You've had him for all 5 days. And every night around this time, he rings on the call bell and says, I'm having my heartburn. I need my Nexium. And each time in the previous 4 nights, you've given him the Nexium, and he feels better and goes back to sleep. In that case, on day number 5, do you necessarily need to do the whole 12-lead and the whole workup for it? And I might say, maybe not. It's exactly the same thing he's been showing the previous 4 nights. It's exactly the same symptoms at exactly the same time with exactly the same onset. Okay, that one's reasonable to say. I think it's the same thing as it has been the last 4 nights. But that wasn't our variant number 1 or 2. That wasn't the way we started this guy off. This was new for him. He's never had it before. Huh. That's weird. What might this be then? And that's where the critical thinking comes into play. Maybe this isn't just heartburn. Maybe this is something else. Second reason why we do this is awareness of the 12-lead EKG order, the benefit of doing 12 leads. This is a little bit of a light introduction if you haven't seen it before, hopefully you have, of acute coronary syndrome, how it shows up, what I need to do for it. The third one is also here, and we've alluded to it a couple times. If you have a critical patient or a deteriorating patient or a patient where something's going not the way it's supposed to, then by all means, call for help. This session is designed for clinician ones. You're not expected to know everything yet. You're not expected to catch everything yet. So by all means, call for help. But in the meantime, don't just back up and wait for them to show up and help you. Keep stepping forward, keep moving your patient's care forward while you're waiting for them to come to you. In this guy's case, you've done a 12-lead that looks, oh, that doesn't look so good. So what can I do while I'm waiting for my LIP and MET to show up? I'm going to stay in the room. I'm going to constantly reevaluate my patient. I'm going to do a new set of vital signs in the next 5 minutes. I'm going to keep the EKG plugged in and attached to him so that we can run another one now anytime somebody wants it. I'm going to maybe, even if my charge nurse maybe knows, hey, when we have something like this, they'll probably want some aspirin. I'll go get some, right? I can't give it yet. I don't have an order for it. But if they do say, oh my goodness, this looks like a STEMI, we should give them some aspirin, you can say, great, already have it. Put the order in, please. Thanks. And make things move forward for your patient. At minimum, stay with them, reassess them, be able to give a good story to whoever is coming to help you. And if they can add more than you thought of, that's great. That's why we have them here. But at least you started this one off well and made it start moving in the right direction. Thank you very much for your time. I hope this was useful for you.